Hi, it's Alicia Bright again. We are going to talk about glucose regulation, as that concept applies to patients with diabetes. So, if you remember from the previous lecture, there are two types of diabetes. Now, just as an aside, actually, there are some studies that are thinking we actually have more types of diabetes than that, actually, up to 5 types of diabetes. So, watch this concept evolve, watch this disease process evolve in terms of how it's diagnosed and defined over the next few years. We do have different subtypes of type 1 diabetics and different subtypes of type 2 diabetics. So it's interesting to see what they're going to come up with as they continue to evaluate diabetes. But these days, we typically think of diabetes in terms of type 1 diabetes and type 2 diabetes. And if you remember, type 1 diabetes is a disease of insulin deficiency. In other words, the pancreas is not making enough insulin. Type 2 diabetes is a disease of insulin resistance. The pancreas is making insulin, but A, it's not enough insulin because B, there aren't enough receptors, or the receptors are resistant to accepting the insulin in order to move the blood glucose into the cell for energy. So we're going to drill down into these two types of diabetes in this part of the lecture. Type 1 diabetes. Now, I have to say, there's a special special place in my heart for type 1 diabetics. Type 1 diabetics are typically children, and my brother was diagnosed at age 7 with type 1 diabetes. This is an autoimmune disease, so there's nothing that you can really do to prevent it. It typically strikes children, but the interesting thing in my family is that my father developed type 2 diabetes in his 40s. Type 1 diabetes in his 40s. Both of these people lost a lot of weight before their diagnosis, and they were very fatigued. So I've got type 1 diabetes in my family from both my father and my son. My son had been diabetic for a good 15 years before my father was diagnosed. But anyway, I've been studying this stuff since I was 11 years old. All right, so type 1 diabetes is an autoimmune destruction of beta cells in the pancreas. When these cells are destroyed, insulin is no longer produced, although it can be kind of produced in fits and starts in the beginning of the disease process, which can make it very hard to regulate blood sugar by administering insulin. It's characterized by hyperglycemia and by a breakdown of body proteins, fats, and the development of ketosis. And if you remember, we talked about ketosis as a cause of metabolic acidosis. So when we talk about diabetic ketoacidosis, think about that acid-base condition known as metabolic acidosis. It usually occurs in kids, like I said, but it can occur in adults. My father developed it in his late 40s. And look at that picture. There's a picture of a little girl administering an insulin shot to herself. And this is what diabetics have to do. Type 1 diabetics are dependent on insulin. They can't take PO medications. They need insulin. And I would just like somebody to correct her technique, please, because her technique is not what I would like it to be. I'm afraid she's going to hurt herself there. I want her to be sure she gets that in her muscle and doesn't wiggle the needle around too much. Anyway, please review your technique for subcutaneous injections. All right, uncontrolled type 1 diabetes, diabetic ketoacidosis. This is what brings type 1 diabetics into the hospital typically. You see the 3 P's: polyuria, polydipsia, and polyphagia. They're making a lot of urine, they're drinking a lot of fluid to make up for all of that, and they're really hungry. They're hungry even as they're losing weight. My brother looked like a bit of a skeleton before he finally was diagnosed. They couldn't figure out what was going on with him. He was eating everything in sight and losing weight and constantly thirsty. 7 years old. They also develop abdominal pain, anorexia, nausea, and vomiting. We were actually on a vacation in Canada when he just finally couldn't take it anymore and he was sick. laying in bed, feeling really yucky and kind of out of it. I remember how his breath smelled, this sweet, fruity odor of breath. Um, and he was diagnosed actually by a rural doctor that we stopped by to see in rural Canada where we were on a vacation. And the doctor's advice was to get him in the car immediately and go straight back over the border, take him to an American hospital. So that's what we did. It was the closest hospital that he could be treated at. And of course, the insurance would cover it. So all the way to the hospital, he was laying with his little head on my lap. I was his big sister. I was about 11, I was about 12 years old at that point. And he was laying there with his head on his lap. I remember that fruity breath smell, and he was pretty much sleeping with his head on my lap. He was out of it. This is typical for a diabetic going into a ketoacidosis coma. And all the way there, he was breathing in and out really heavy, in and out, in and out. Those Kussmaul's respirations. Deep in, deep out, deep in, deep out, kind of continuous respirations because his body was trying to blow off CO2 to balance the pH, given the ketones that were driving his body into metabolic acidosis. This is something you never forget. Diabetic ketoacidosis is defined by a blood glucose level of 250 or greater, and I believe his was around 500 when they admitted him. The pH will go lower than 7.3, so this is a metabolic acidosis. The bicarbonate level will go low because that's part of what goes on with this. It negates the bicarbonate. And you'll see ketone levels in urine or serum. Ketones, of course, are the breakdown products when the body is breaking down its own tissue and deriving some energy from proteins and fats. Ketones are produced. So that's type 1 diabetes. In order to treat it, people have to have insulin replacement. That's the only thing that treats it. And we'll talk about the diet involved with that in a little bit. First, we're going to go over type 2 diabetes. Now, type 2 diabetes is the most common type of diabetes. Now, we don't have this in my family, but it's very common in many families. It runs in families. Type 1 diabetes actually is very rare within families, but type 2 diabetes tends to run within families. Usually, we'll see this in middle-aged or older individuals, but we will see it in younger adults. In fact, my son, when he was in high school, had a friend who was diagnosed with type 2 diabetes at age 19 and actually died of complications of type 2 diabetes when he was 21. So it can strike younger people now. Now, this was a kid that was very obese. He was not very physically active. He was a computer nerd, along with my son, the computer nerd, and this guy happened to become diabetic. He was able to start getting it under control with exercise and diet, but I'm not sure what happened. I suspect it had to do with medications. Type 2 diabetics take PO medications. Anyway, he went to bed one time and did not wake up. So it can happen to younger people also. But typically we see this with older people. So type 2 diabetes is a situation when the amount of insulin is insufficient to lower blood sugar levels. So the cells in the body are not taking up the blood sugar fast enough. The cells are resistant to the insulin. It's a gradual, slow onset. Type 1 diabetes comes on over the course of 2 or 3 months. Type 2 diabetes can take several years to come on gradually. And then people may have some polyuria, polydipsia. Often the thing that brings them in is blurred vision. They go to their ophthalmologist and say, hey, my eyes aren't working very well. The ophthalmologist will examine the back of their eyes and say, when was the last time you had your blood sugar checked? Send them to their doctor. So you're going to see polyuria, polydipsia, and fatigue and not feeling very good. again, the kidneys are trying to wash out the sugar through the urine, and they're going to be thirsty, so they're going to be trying to replace that fluid, but they can start having these other symptoms. Risk factors include a family history of it. Obesity is a risk factor for type 2 diabetes. Obesity is considered to be one of the most strong indicators of it. Although, as I said, there are probably more types than simply 1 and 2. I've seen non-obese type 2 diabetics. There's more to it than we know at this point. If you're interested in diabetes, there's a wealth of information out there that you can get into. The science is growing quickly, and we have a big need for diabetes educators, nurse educators. That's one specialty you could go into, actually. So anyway, being physically inactive is a huge risk factor for type 2 diabetes. My son's friend, who was into sitting around and working on computers, that was part of the problem. My son was very active, but he was not physically active. So for women, history of gestational diabetes, remember we talked earlier, gestational diabetes resolves after the baby's born, but once you've had it, you have a 67% greater chance of becoming diabetic than you would have otherwise. Polycystic ovary disease can also be caused by higher blood sugars. And delivering a baby that weighs greater than 9 pounds, those people are considered to have been probably undetected gestational diabetics. Metabolic syndrome is part of the diabetes type 2 picture. People with type 2 diabetes tend to have higher blood pressure, higher cholesterol levels, and higher triglyceride levels. This is sort of the 3 prongs of metabolic syndrome. When we see these in people, we expect that they will be developing type 2 diabetes. So the good news about type 2 diabetes is that actually regular physical activity can prevent it. Avoiding excessive calorie intake can prevent it. This is another reason why you want to strive for a healthy weight. Have a healthy diet, whole grains, vegetables, fruits, and beans, low-fat dairy, lean protein sources. So are there any surprises to this diet? This is just basically your all-around good, healthy diet. It is helpful for preventing heart disease, preventing diabetes, preventing high blood pressure, pretty much everything we talk about. If it's preventable, diet is part of it, and by now, you ought to be familiar with basically a healthy diet. So we're going to be monitoring these folks' blood sugar. Any blood sugar, if it's greater than 100, we're going to start worrying about these people becoming type 2 diabetics. Any blood sugar greater than 200 are the signs of symptoms of diabetes, and we will call it a diabetic. We dip urine for glucose and protein. So we used to dip urines all the time. Now we can dip for, if they're spilling protein, that's pretty severe. We'll be doing lipid assessment for total cholesterol, HDL cholesterol, and triglycerides, looking for that metabolic syndrome also. Now, you have all probably taken somebody's blood sugar at this point. I hope some of you have had a chance to check blood sugars and even to give an injection of insulin. That's a pretty basic thing that nursing students usually get a chance to do right away. That's all well and good, but the gold standard for blood sugar testing is the hemoglobin A1C. So we have the oral glucose tolerance test, which is the first item on this list, and that helps us to diagnose diabetes. The way it does that is if they drink the sugar, they go in fasting and they check a blood sugar. Then they drink a large glass of glucose and they watch how fast the blood sugar levels go up. And then they watch how fast they go down. And for diabetics, they won't go down. The body can't metabolize the glucose like that. So that's considered conclusive, but really it's kind of a miserable test to have. And the gold standard in diagnosing diabetes is hemoglobin A1C. Remember, hemoglobin is replaced in the body about every 3 months as the red blood cells turn over every 3 months. The products of the red blood cells get broken down and recycled, really. So when the hemoglobin is produced, it circulates in the body for about 3 months and gets a certain amount of sugar attached to it. So that's what it is. What it does is it gives you kind of an average of how much sugar has been in the blood over the last 3 months. So a reading of greater than 6.5 is indicative of diabetes. So what we want is for normal people should have a blood sugar reading or a hemoglobin A1C reading of less than 6.5. For diabetics, we don't mind them going over a little bit. We want it to be less than 8. And if we can, we'd like them to be less than 7. The problem is if we try and keep too tight control on of diabetes and blood sugar levels, the person might go hypoglycemic. And of course, hypoglycemia is more acutely dangerous than hyperglycemia. So we'll allow a little bit higher level of A1C and still consider that to be normal for diabetics. So the goal for everybody, if you're healthy, your hemoglobin A1C is going to be less than 6.5 or equal to it. If you're a diabetic, we want it to be less than 8. That would indicate good management. And really excellent management would be less than 7. So this picture is just, a warning about those donuts that we all know and love, and you find them around the nurse's station periodically. People love us. They bring us donuts. Well, the donuts help raise your blood sugar levels and send your hemoglobin A1C up. Just making the point. Sugar raises your hemoglobin A1C. So the key to diabetes management is teaching. We talk about how we are managing diabetics, but the bottom line is diabetics manage themselves at home. My brother and my father both. My father was a mathematical biologist. He was a medical researcher. And he got this thing down to a science. He read all the latest. He was doing carbohydrate counting before it was a thing. The doctors thought he was crazy, but he had read the latest research. We're going to talk about carbohydrate counting in a minute, but let me just tell you, some of your diabetics are going to be not knowing how to manage themselves at all. And of course, others have gone online and read all kinds of stuff, some of which may be really useful and some of which may not be really useful. So you want to sort through what does your patient know and what do they need to know, and do some really good education, because as much energy as we put into managing patients in the hospital, they have to put way more energy into managing themselves at home. Diabetes is a 24/7, 365 condition. It's up to the patient, really, to manage it and to avoid hospitalizations for it. So education is key. And as I said, if you want to be a diabetes nurse educator, there's a huge demand for it right now. So the bottom line is patients who have diabetes need to learn the relationship between glucose, diet, and exercise. They need to learn how to manage their blood sugars. They need to learn how to monitor their blood sugars. They need to learn how to test, how to care for the equipment, what to do if their blood sugar is high or low, and we're going to talk about that. They need to know what the manifestations of hypoglycemia and hyperglycemia are and what to do when they happen. And again, we're going to talk about that. They need to know what medications to take. So type 1 diabetics will be taking insulin, period. It's the only thing that helps. They may have other problems with other disease processes, comorbidities that they'd have other medications for, but the insulin is for the diabetes. Whereas type 2 diabetics, they're on PO medications. They may be on insulin also, but they are on PO, anti-hyperglycemic agents. I'm going to deal with that in a separate lecture. So they also need to know really good foot care, really good skin hygiene, hygiene in general, skin care, dental care, and foot care. My brother went out as a young adult. He was in high school, and he and a bunch of other kids were playing on a great big beautiful lawn. They were playing touch football, and they were kicking this ball around. Of course, they were running around barefoot because that's what teenagers do, right? I used to do it. And he was out there running around barefoot, and he stubbed his toe against a sprinkler head. Well, ouch, darn. You pick up, you keep on running because, you're a big tough guy and, you just stubbed your toe, no big deal. Well, he ended up in the hospital on IV antibiotics because little problems with feet can blow up into big problems with feet very quickly with diabetics. The higher blood sugars create the ideal environment for infection to grow. So we want to protect people's feet. They should be wearing supportive shoes that fit correctly. They should not be running around barefoot. And they should check their feet every day for cuts or bruises. Keep cracked skin hydrated. Take good care of their feet. So this is a picture of something that happened. People who've had diabetes for a while will have neuropathy most often, and they'll have decreased feeling in their feet. So if they don't inspect their feet regularly, little cuts could sort of persist and become infected. And this here is a picture of an ulceration that happened on the foot that's just not healing well. So a little review for wound care here. How would you describe this wound? I would say it's an open wound. It's healing by granulation. So remember, first intention was a cut that was sewn up again and heals that way. Second intention was a cut that was open, and because it became infected, it dehisced. It opened up because it was infected. Now it's healing through second intention and granulating. Well, this is a chronic wound. I would measure this wound from a couple of different angles. I would describe it as pretty round, maybe a little bit ovular. And inside it looks like it's got some possibly purulent drainage or even eschar in there. And a little bit of the area around it looks like there might be some necrosis. Anyway, this wound needs serious attention. If wounds are not treated, diabetics end up with amputations. It's actually the largest cause of amputation of toes and feet in the country. So let's teach our patients. They need to learn about good diet. This is vital for both type 1s and type 2s. Dietitians may provide some instruction. Like I said, diabetic specialists, diabetes nurse educators will provide instruction. But just regular floor nurses, we teach and we also reinforce the teaching. I want to talk about carbohydrate counting because that is the most effective way. It's considered a gold standard. It's the most effective way to count carbohydrates or to manage blood sugars. So carbohydrate counting, this is considered the gold standard for caring for diabetes and most particularly for type 1 diabetes. So we'll want to consider the most effective way to manage the diet to control the blood sugars. This is considered the most effective way. Getting a little tired here, talking too much without anybody to talk to, but here we go. So we consider 15 grams of carbohydrate to be a standard serving. We consider that people will usually have 3 to 4 servings of carbohydrate per meal. So carbohydrate counting involves checking blood sugars before meal and figuring out how many servings of carbohydrate you have. Now, the doctor will prescribe how much carbohydrate would require how much insulin, and will also prescribe a sliding scale for insulin. You've probably seen that at this point. A sliding scale is where the doctor says, okay, if they have blood sugar level of of a 100 to 50, we're not going to give insulin. If it's 50, it's 150 to 200, we're going to give 2 units of regular insulin. If it's 200 to 250, we'll give 4 units of regular insulin. Remember the sliding scales that you see? Okay, so the way carbohydrate counting works is first the patient takes their blood sugar, and then they count up how many carbohydrates they have. Now, if they're taking 2 units per 15 grams per serving of carbohydrate, they count up the carbohydrates and they're going to take 2 units of insulin per serving. Now, if they're on a sliding scale that says, and this is all prescribed by the physician, sometimes it's 1 unit, sometimes it's 2 units, sometimes it's 3 units per 50 points. If it's, say, 2 units per 50 points of blood glucose over 100, I'm lowering it a little bit here from we're tight control. Say the person has 45 grams of carbohydrate, well, they're going to cover that with 6 units, right? Say they have blood sugar of 236 before a meal, say that means they should get 6 units to keep their blood sugars down. So just before eating, they'll take 12 units of regular insulin and start dinner. The saying is, give the shot while the meal is hot. So the food gets to them, they take their insulin and immediately start eating. This is because they're taking a high dose of insulin. This will not just bring their blood sugar down to where it should be. This will bring their blood sugar down to where it should be and keep it there even as the carbohydrate enters their system through digestion. Does that make sense? We're trying to manage blood sugars to normal levels and manage them through that time period when the food is going to go into their systems. We want to keep the blood sugar low. So there are other ways to manage diabetes besides carbohydrate counting. The exchange list, that was what my little brother grew up on. There's certain amount of starch, fruit, milk, meat, fat, different things that they can do. And they have, for instance, for each meal, they're allowed 2 breads, or the doctor will prescribe it, but 1 fruit, 2 meats, whatever it is. And then they choose, they know what things fit in that category, and they choose their diet to have the prescribed amount. The USDA MyPlate method is probably something you can find on the USDA website. And they have a MyPlate for diabetics. And that helps divide up what people are eating, prescribed specifically for diabetics. The consistent carbohydrate diet, that's kind of a no-brainer diet. You just eat exactly the same kind of carbohydrates for each meal every day. And then, theoretically anyway, the same amount of insulin is going to keep your blood sugar at the same rate every day, all day. And actually, it doesn't work out that way because your metabolism changes, your body's needs changes, your exercise level may change. So actually, your blood sugar levels are going to change. But we do that for people who really can't understand the more complex ways of doing it. This is a really simple diet for somebody who's very uneducated and not very engaged in really trying to figure out how to help themselves, but is willing to do certain things. So this is a really simple way of doing it. I want to say one word about the glycemic index. Glycemic index is a scale that it's not as it was a kind of a brilliant thing a few years ago. They're saying now it's not as reliable as they thought it was, but basically the glycemic index ranks foods on the basis of how quickly it goes into your system and how fast it will raise your blood sugar. So donuts, really high on that glycemic index scale. You eat that stuff, it goes right into your system, straight into sugar, zing, sends your blood sugar right up. White potatoes, baked potatoes, same thing actually, high glycemic. Ironically, sweet potatoes are a little bit slower to enter your system. Um, Boiled potatoes go into your system more slowly than baked potatoes. My father figured that out, and turns out research demonstrated that it was correct. Other things that are lower in the glycemic index, whole wheat, whole grains are lower in the glycemic index than refined stuff. So white flour, it's right up there with white sugar. However, quinoa, whole grains, those things go in a lot more slowly. So we want people to choose foods that don't pop their sugar up too high. So, diabetes and exercise. As we said, diabetics must exercise, kind of like all of us, only even more important. They need to monitor their blood sugar carefully while they're exercising. I have to say, my brother actually discovered, and it turns out that it's true, again, that with diabetics who observe themselves carefully learn a tremendous amount about this, and then, research will or won't demonstrate that they're correct. My brother, who is actually still healthy, he was diagnosed at age 7. He is now 54. He's still practicing martial arts. He's still very athletic. He is starting to experience some of the side effects like gastroparesis, and he's starting to have some peripheral neuropathy and a little bit of issues with his eyes. But, considering the fact that the doctor told him he'd be dead by the time he was 30, he's doing pretty darn good because of constant exercise. He's practiced martial arts all his life, and carefully monitoring his blood sugars. So a good workout will lower blood sugars up to about 48 hours after exercise. It also lowers triglycerides and LDL, and it increases your HDL. It improves your blood pressure, and improves your circulation. So good exercise for diabetes is going to stave off those bad complications of diabetes. Things to remember, though: if the blood sugar is greater than 300, don't exercise. It's too high. Get your blood sugar down first and then exercise. Also, don't exercise if ketones are present in urine. That means the body is already breaking itself down. You don't want to exercise now because obviously if the body's breaking itself down, you're not getting enough insulin into your cells for your cells to have energy to exercise. So you want to be in a stable condition before the patient is exercising. You want them to be stable. A little bit about the rule of 15. If your blood sugar is low, and this is particularly important for diabetics, but also for type 1 diabetics on insulin, but also for type 2 diabetics. If blood sugar is low, so less than 70, you're going to eat 15 grams of carbohydrate, and then you're going to wait 15 minutes. Now, why do you wait 15 minutes? Check blood sugar again, right? Well, if you think about the digestive process, it takes a little while for the food to get into the system and raise blood sugars. So eat carbohydrate, wait 15 minutes, and then check the blood sugar again. If it's still low, you're going to eat another 15 grams of carbohydrate and wait another 15 minutes. If it's still low, guess what? You're going to wait another 15 minutes. You're going to eat another 50 grams of carbohydrate. You're going to wait another 15 minutes. You're going to check blood sugar again. If it's still low at that point, something really weird is going on, and you need to get yourself in to be seen. But we teach diabetics to do this so that, 99 times out of 100, this is going to fix the problem. But if they check their blood sugar too quickly, they won't be able to have a blood sugar that reflects the food that they just ate. So, having low blood sugar may be a great excuse to eat that chocolate bar. But if you eat that chocolate bar, gosh, it's really good. 5 minutes later, I'm checking my blood sugar. Oh, it's still low. I get to eat more chocolate bars. Yeah, well, an hour later, you're going to have hyperglycemia, and you got a whole different kind of trouble going on. So rule of 15. This is important to know. Now, about sick days. So diabetics who get sick are at high risk for complications of diabetes because in an infective process, the blood sugar raises. It stresses the body, and when the body's under stress, it wants to have access to energy, so it raises blood sugar levels. This is a problem, particularly for diabetics. So even though they're not eating so much, the blood sugars may go up. So we really need to stay concentrated on preventing dehydration on these people. We want to provide nutrition, but we particularly are careful to prevent dehydration. So sick day management includes monitoring blood sugars at least 4 times a day. My dad used to check his blood sugars 5 or 6 times a day. He was a little obsessive compulsive about it, but he also had really tight control. He'd also go really low. But anyway, monitoring blood sugars at least 4 times a day is very important. Testing urine for ketones. If the blood sugar is going up, you need to test for ketones. That's for type 1s. People need to continue taking their prescribed insulin or their prescribed hypoglycemic agents. Don't stop taking the medicines, or blood sugar could spiral up out of control and you end up in either diabetic ketoacidosis or hyperglycemic hyperosmolar syndrome. So sipping fluids is the most important thing to do to manage sick days. Eat things that are easily digested. And if the patient can't eat for more than 24 hours, time to call the doctor. All diabetics should have some kind of medical alert on them. They can have a medical alert bracelet. Some of them have tattoos. And, people should have this in their cell phones. They're in case of emergency part of their cell phones. They should have all kinds of health information in case they were found unconscious and couldn't explain what was going on. Healthcare providers need to know that they're diabetics. Helpful resources for diabetes. Well, the American Diabetic Association. They have, for almost 100 years now, provided education, research, and support for diabetics. So the American Diabetes Association, the American Dietetic Association is a resource for nutritional information, and the National Diabetes Information Clearinghouse talks about treatment for diabetes. Of course, now that we've got the World Wide Web, we've got all kinds of wacky suggestions going on. So you want to encourage people to trust vetted sources. And these 3 organizations have been vetting diabetic information for decades. So there you go. There's your introduction to diabetes. I'll talk about meds in a subsequent lecture. Thanks.